नीरज, हम भी इसको रिकॉर्ड करते हैं तो कहाँ जाता है ये? तुम्हारे ऑफिस में?
सर मतलब कहीं पे डिस्प्ले तो कहीं डिस्प्ले तो नहीं होता है सर।
जैसे रिकॉर्डिंग इन प्रोग्रेस हो गया।
सर वो मेरी अंडरस्टैंडिंग है कि सर सेव होके रह जाती है एज ए फाइल, बट अभी तक कहीं पे कोई डिस्प्ले नहीं होता है, मतलब ऐसा कोई यूट्यूब पे या कहीं पे, या यूट्यूब पे लाइव चल रहा है, बट बाद में कोई ऐसा डिस्प्ले तो नहीं होता है सर।
अच्छा।
जी।
ये आईसीएच ऑफिस जो लिखा रहा है, ये गौरव वो करता है कंट्रोल?
हाँ जी सर, गौरव कंट्रोल करते हैं सर।
हम्म।
Is ICH and Delhi IAP
यस सर।
and Gangaram.
सर
आईसीएच इज गंगाराम,
हाँ,
इंस्टीट्यूट ऑफ चाइल्ड हेल्थ गंगाराम।
अगर
Okay,
गंगाराम
ICH.
का ही सर पीडियाट्रिक डिपार्टमेंट इज आईसीएच।
Okay.
दैट्स व्हाट। चलो। तो ऐसा में क्या कवर करने वाला है आज? इट्स वास्ट टॉपिक।
सर मैंने कोशिश किया है कि एक केस से स्टार्ट करेंगे और उसके बाद में देन आई विल ट्राई टू कवर, क्योंकि ये स्टूडेंट्स है, पीजी स्टूडेंट्स हैं, सो आई विल ट्राई
हम्म।
टू टेक सम बिट्स ऑफ हिस्ट्री, देन उसके बाद में थोड़ा सा स्पायरोमेट्री सो दैट सेंसिटाइजेशन हो जाए, उसके बाद में थोड़ा सा ऑसिलोमेट्री के बारे में बात करेंगे, फिर थोड़ा फार्माकोथेरेपी, फिर थोड़ा सा अवॉइडेंस, फिर इम्यूनोथेरेपी। तो एवरीथिंग आई हैव ट्राई टू कवर अप लिटिल लिटिल, क्योंकि सब कुछ तो कवर नहीं कर सकते सर। जी।
हाँ, इट्स वास्ट टॉपिक।
जी
And the duration you'll keep for complete 1 hour or little less?
sir, so I will speak probably around 40 minutes, and then later on for next 5 7 minutes we can discuss. If we have something or some question is there, then we can discuss about that. So
ठीक है।
questions usually come in chat box
हम्म।
if they are there. Doctor
Uh,
Anup joining.
Good evening, everybody.
Sir,
हाय
good evening.
अनुपम।
Hi, sir. How are you? Hi, Deepak.
Good
वेरी
evening.
गुड। बढ़िया हैं।
Uh, what we will, the questions will not come in the chat box, will come more in the question answer box.
ओके।
Okay,
ओके।
okay, sir.
Because the usual audience is not allowed to put things in the chat box, because only the invited audience is on the chat box.
ओके।
Okay, okay.
We'll just wait for another minute or so and then start the
Sure.
program.
Fine.
राइट।
In fact, we'll have plenty of pediatricians joining this program, because in addition to the postgraduates, the pediatricians also join the program in a big way.
ओके, गुड।
So sir, I will keep my talk in such a way so that everybody will get at least some part.
Yeah, yeah.
यस।
So I'll welcome everybody to this faculty lecture. I think now it is almost 4 years that we have started these faculty lectures and case presentations. Faculty lectures on Thursdays, and Wednesdays we have case presentations. For today's uh, faculty lecture, we have Dr. Kishan Chugh as the moderator. Uh, Dr. Chugh needs no introduction. He has been the mentor for all of us in Gangaram, and was instrumental in setting up the pediatric intensive care unit there in Gangaram. And uh, I have been lucky to work with him, and and learn a lot of things from him. Uh, he continues his innings, and very ably so. The chairperson of the uh, lecture is Dr. Deepak Ugra. He is an ex-president of the Indian Academy of Pediatrics, a person who has got a special relationship with me We have together done a lot of programs, and in the DNB program also, he's one of the architects of pediatrics DNB and has been conducting the examinations in Lilavati Hospital. We also have Dr. Gurno Minhaj Sheikh, who is also a pediatric intensivist who's working with Dr. Deepak Ugra in Lilavati. And we were lucky to have him as a student and a candidate from our hospital. And then he settled there in Bombay and doing great job under the leadership of Dr. Deepak Ugra. I'll request Dr. Chug and Dr. Ugra to please introduce the topic and the speaker. Maybe Dr. Ugra can introduce the topic and Dr. Chug can introduce Dr. Neeraj Gupta.
So first, Deepak first.
Thank you, Dr. Anupam Sachdev. Thank you, ICH and IAP Delhi, for having this one of the most common problem that we face in our OPD, not to that extent in IPD, but in OPD. And like Dr. Anupam said, that he was lucky to work with Dr. Krishin Chog. I am also one of them who has worked with Dr. Krishin Chog in IAP for decades,
Yes.
6 years. And I'm so happy that we are together again on an academic platform today. So I think I hand it over to Dr. Krishin Chog, who needs no introduction, as Dr. Anupam has said. Couple of lines that what he has contributed in IAP is that he was the founder chairperson of intensive care chapter of IAP, which is doing so well now. He was a former chairperson of even the respiratory chapter of IAP, of which the activity that we are going to discuss today. He is the former director and chief ICH of Sir Gangaram Hospital, former associate editor of Indian Pediatrics, one of the very popular and journal of our own Indian Academy of Pediatrics with a very high impact factor. He is the former chancellor of College of Pediatric Critical Care, former vice president of IHCCM, and so many things. I request now Dr. Krishin Chog to take over on this important topic and ask my introduce the speaker of the day. Thank you.
Thank you, Deepak, and welcome, Dr. Lelan. Okay, so we'll come to Dr. Neeraj first. He is currently working at Sir Gangaram Hospital. He looks after the allergy, and the pulmonology, and has contribution in critical care. So that's where his interests lie. And for a long time, he's been the leader in the allergy domain. He has represented, let's say, India in many of the international conferences. One was very recent in Valencia of Spain. He's written textbooks also on allergy, collaborated with others who have written. So that way he's somebody who is just the right person to talk about all aspects of bronchial asthma. So we'll hand over to him. And just before that, welcome Dr. Pankaj Garg.
Thank you, sir. Thank you for the introduction. I will start with the topic today. So today's topic is on childhood asthma, and I will be speaking a broad outline about the diagnosis and management. As sir was mentioning earlier, that asthma itself is a very vast topic. So everything and anything cannot be covered in any length of time, or probably 1 hour of time. But still, we will try to highlight few important points, few salient features of different domains of asthma, and we will try to cover up the common things which often are encountered by the pediatricians. So I will take a help of a child, Rahul, who is an index case, 9-year-old, 50 kg child. So it suggests that it seems to be like overweight child. Cough and breathing difficulty presented with 3 years. And the symptoms seems to be more in the late evening and early morning hours with frequent night awakening. The symptoms are milder around the year with frequent exacerbations during September, October. And most episodes are preceded by sneezy, itchy, and blocked nose, which seems to be more problematic for past 1 year. So here in this slide, we understand that there is some chronic problem of coughing and breathing difficulty involving the respiratory system, which is happening for past few years, and which is also having some diurnal variation and also affecting the sleep. And simultaneously, the problem seems to be perennial with some seasonal exhibitions. The problem also seems to be having an involvement of another system, which is nose, and which is more recent as compared to the chest. So in the past, there was a history of eczema in the early childhood. So probably this child has traveled through the atopic march, and that's why we are getting a history which is suggestive of atopic dermatitis or eczema in the infancy or early childhood. And then now we are dealing with some sort of asthma type of features and rhinitis. In the family, there is a history of rhinitis, suggestive of rhinitis in father, and cough with breathing difficulty in the younger sib, who often requires nebulizers when the problem increases with seasonal change. So there is definitely a family history, a strong family history which is there. On inquiring further, the grandfather says that he is smoking BDs, but he mainly smokes outdoors. He doesn't smoke indoor. So there are certain environmental factors which are also playing around. Grandmother, very religious lady, and she uses incense sticks for prayers often on the daily basis. Rahul also has a dog for past 3 years, and they reside in the, you can say like in South Delhi, near Ashram Chowk, which is considered to be, you can say like a very busy area, and the pollution levels in the environment, they are high. So what I suggested that there is a genetic predisposition, there is a clear-cut history, and there are certain environmental factors which are coming up in this case. On examination, the Rahul seems to be visibly overweight. There are allergic shiners which are there, and chest is having occasional wheeze. So issues with Rahul are that he seems to have asthma, which seems to be perennial problem with some seasonal exhibitions, seems to have traveled through the atopic march with past history of eczema and now recent rhinitis, positive family history, that means atopy, obesity is there, and then there are triggers which are also there, outdoor pollution as well as some animal dander, and then the third hand smoke, which was also there. So we all understand that we are probably dealing with asthma. So what is asthma? Asthma, as per the GINA guideline, it is a heterogeneous disease which is characterized by chronic airway inflammation with history of wheeze, shortness of breath, chest tightness, and cough. So these are the 4 cardinal features which are there of asthma. And the important thing is that these symptoms can vary over time and intensity. And simultaneously, we need to actually have a documentary proof of variable expiratory flow obstruction. So history usually is sufficient, as I have already mentioned during the initial 2 or 3 slides. It is usually sufficient to suspect asthma, but still to write it on the paper, to diagnose it, we need to really demonstrate expiratory airflow limitation and with reversibility. Here, this flowchart also says from GINA that whenever you are suspecting any particular child suffering from asthma, then you need to really perform some lung function test, which is spirometry or PEF with the reversibility test, and see whether this particular test is supporting the diagnosis of asthma or not. So I will be talking a brief about this gold standard test, which is called as spirometry. So let us understand that what is breath. So breath, we understand that this is something like a process in which air is going in during inspiration and then coming out during expiration. So it is as simple as that. It is not equivalent to respiration. Respiration is more complete cellular process in which oxygenation and removal of carbon dioxide is also happening. But here, breathing is just a procedure in which inspiration and expiration, both things are happening at the chest level. Now, can we quantify this breath, or can we quantify this air which is going in inspiration and expiration? So if we just see very carefully this particular graph, so during inspiration, this red line, which is coming below the baseline. Why it is coming below the baseline? Because this is like a spontaneous breathing. It is a negative pressure breathing. And that is why during inspiration, the air is sucked in, and then during expiration, the air is moved out, which is depicted as a blue line here. Now, the question is that this inspiratory and the expiratory volume or the flow, if we measure through a certain maneuver, then that will tell us about the different volumes and capacities of the lung. So what are these different volumes and capacities? So these are the different volumes and capacities. If we just want to see forced vital capacity, I will come one by one to each these terms, but the commonly used term, which will be using 3 terms, FVC, FEV1, and FVV1 by FVC. So what is FVC? FVC is basically like the total vital capacity, which is including, so let's see this diagram. what is happening in the tidal breathing. So this is the tidal volume. And then when a person takes a deep breath in, so this extra volume which is taken in is inspiratory reserve volume. And then after that, when the person is expiring forcefully, then the extra volume over and above the tidal breath is called as expiratory reserve volume. So what is vital capacity? Vital capacity is the combination of inspiratory reserve volume, tidal volume, and expiratory reserve volume. That means point from here till here. And if you are performing it with a force, you want to blow out as forceful as possible, as quickly as possible. So it is called as forced vital capacity, FVC. So when we are performing spirometry, then at that time, we actually want to see from here till here as quickly as possible, as much forceful as possible. That is FVC. Then coming to the second term, which is called as FEV1. So out of this FVC, whatsoever proportion is coming out in the initial 1 second is called as FEV1, which is force expiratory volume. So that is called as FEV1. So we need to really demonstrate this FEV1 by FVC, that it is reduced. And normally it is considered that anything which is less than 80% in a healthy adult is considered to be abnormal. And for pediatric age group, it is 85 to 90%. Less than 85 to 90%, it is considered to be abnormal, FEV1 by FVC. So this is the first step, that there is an airflow limitation. And then thereafter, we have to really demonstrate about the reversibility. So when we give the bronchodilator, then at that time, if there is a more than 12% response or more than 12% increase in the FEV1 value, then it becomes reversible. So these two steps are really important. Then there are other things like diurnal variability and 4 weeks variability, which can also be seen. But the main thing is that reduction in FEV1 by FVC and FEV1 improvement on bronchodilator instruction. So this is important. So this graph also suggestive of the same thing. So this is the volume time curve, in which for a normal curve, which is a green line, in the 1 second, this much is the volume which is coming out. So suppose if it is because of some, you can say like asthmatic problem, like if you see the red line, then at that time this FEV1 will reduce significantly, and you give bronchodilator, then at that time there is some reversibility which is happening, like a blue line. So this is FEV1. So this is volume time curve. And similarly in the flow time curve, flow volume curve, if you just see that what is normal, normal has to be like a green line. And if you just see in asthma like a red line, so in this red line, there is a significant reduction in the flow. And if you give bronchodilator, then there is some improvement. Now the question is that though we understand that spirometry is gold standard, but suppose if the child is unable to do spirometry, can we do something else? Like there are children who cannot perform spirometry, 6-year-old, 5-year-old, 4-year-old. There is a typical history, seems to be asthma, but we are often feared to label them as asthma. So can we demonstrate this lung function in them? So yes, we can demonstrate. So there is another technique which is called as oscillometry. The main principle of oscillometry is that it is working on the tidal breathing. We are not asking any particular patient or child to breathe forcefully. So it is just working on the tidal breath. And on that tidal breath, the sound waves are going in and coming out. And then we are measuring the characteristics. So this is a very small setup of oscillometry which can be used. And this is one cartoon which will actually help us to understand how this oscillometry is working. So like if the child or the patient is breathing from this point here as a respiratory flow, which is going inside the lungs and coming out. And now if you see as a green arrow, this sound wave is tiding over the tidal breath, going inside, and as a blue arrow, as a mark of depiction, the sound signals are coming back. And then these sound signals are filtered, and thereafter they are captured by the pressure transducer and the flow transducer. So they are directly monitoring, they are directly measuring the pressure and the flow for individual sound signal on an individual frequency. And by using Ohm's law, machine calculates resistance by pressure divided by flow. So for each and individual frequency, you will actually come to know that how much resistance is encountered inside. So when we talk about resistance, then at that time, it all depends upon that which sound frequencies which are using. So the commonly used sound frequencies are lower frequency, which is 5 Hertz, and higher frequency, which is 20 Hertz. The lower frequencies have more power, so they will tell us about the entire airway characteristic. The higher frequencies have lesser power, so they travel lesser, so only proximal airway characteristic they tell. So if we are really interested in the total airway resistance, it is the resistance at lower frequency, which is R5. If we are interested in the large airway resistance, so it is the resistance at higher frequency, which is R20. And if you just simply do a mathematical deduction, then you will just come to know about the small airway resistance. So what I want to say that there are methods which are available, which can actually be used in smaller children, in children where you cannot really perform spirometry. And then there are different graphs. I'm not going in detail about the graphs, but the message is that yes, there are methods and oscillometry can be performed after 2 years of age. So this is one chart which is actually depicting the overall interpretation of oscillometry. So this child, Rahul, he is actually suggestive that pre-bronchodilator, this faint red line is the pre-bronchodilator curve, and which is showing a reduction in the resistance values post-bronchodilator, which are the dark lines. And this line is suggestive of small airway problems. So which is also reflective that yes, this particular child seems to have airway obstruction, which is predominantly affecting the small airways and which is associated with reversibility. So it is consistent with asthma. What are the differences between spirometry and oscillometry? So spirometry, we all understand, it is based upon certain flow rates and lung volumes, whereas oscillometry actually tells you directly about the resistance by applying the Ohm's law with the transducers, measuring the pressure and the flow. The type of breath here in the spirometry is used as a forced maneuver, whereas in oscillometry it is a tidal breath. Patient cooperation is highly required for spirometry, so usually bigger children can only do, and sometimes even an adolescent or an adult finds difficult to do spirometry procedure. Whereas in oscillometry, you can actually do after 2 years of age or 2.5 years of age, if the child is able to understand the simple command of breathing at the tidal breathing with keeping the mouthpiece in the mouth. That's all. And otherwise, the sensitivity for the small airway problem detection is also higher with oscillometry. And we actually require some reference values and standardization of the oscillometry method, for which multicentric trials are needed. But otherwise, it seems to be a good tool. So coming back to Rahul, how to manage this child? So as per the gene saying, 9-year-old child with this algorithm, children 6 to 11-year-old. So the child seems to be started with step 4, as the symptoms are mostly on the days, and the child needs to wake up with the asthma problem, and symptoms are once a week or more, and with the low lung function. So all these things are there in Rahul. So that means he needs to be started on step 4. What step 4 says? So step 4 says medium dose inhaled corticosteroid LABA combination, or a low dose ICS formoterol maintenance, and reliever therapy, which is MARD therapy, right? So what are these doses? These are the doses here for different age groups. So one is for the 12-year and older, and another one is from 6 to 11-year-old, in which low dose, medium dose, and high dose. So Rahul was started on MARD therapy with budesonide of 100 microgram and formoterol of 6 microgram inhaler, 2 puffs twice daily. That means 400 microgram of budesonide was started along with the formoterol combination, that is MARD, per day. With the spacer, adequate technique was explained. So which was falling as per the previous chart into medium dose ICS with LABA. When we followed up the child at 3 months follow-up, so what we have found that the symptoms are poorly controlled. How we can assess that control? So usually we see that in past 4 weeks, these are the 4 characteristics which we usually need to monitor. Whether the daytime asthma symptoms are more than twice per week or not, any nighttime awakening is still present or not due to asthma, SABA reliever for symptoms more than twice per week is required or not, and any activity limitation due to asthma. So if child is considered to be well controlled, if all the answers are that no, the child is doing absolutely fine. Whereas he is absolutely uncontrolled if majority of the answers are yes. And if we are somewhere in between, that is 1 to 2, that is partly controlled. So here in case of Rahul, he seems to be still poorly controlled, and there was frequent need of SABA as well as night awakening was present. And he has to miss the school often in between. So that means that the child is not controlled yet. What could be the potential causes in such a condition? It is the incorrect diagnosis. Are we actually not dealing with asthma? There is something else which is going on. Or it is asthma, but the technique which we have explained, but the parents or the child is not taking that technique or using the technique properly. Or the doses, whatever we have recommended, they are not the appropriate doses or adequate doses. He needs higher doses. Or there are certain comorbidities which we forget to address at this particular time. So what are the differentials? So in this particular age group, like 6 to 11-year-old, so there could be different conditions like chronic upper airway cough syndrome, which is usually presenting with sneezing, itching, blocked nose, throat clearing. So this is there in our child. Inhaled foreign body, bronchiectasis, PCD, congenital heart disease, BPD, and cystic fibrosis. So these could be the differentials for this particular age group with different presentations. Whereas from 12 years onward till you can say like late adulthood, there could be other differentials which can also come up, like inducible laryngeal obstruction, hyperventilation, and dysfunctional breathing. So they all can come. So here in this particular child, Rahul, we rechecked the diagnosis, and it seems that the diagnosis seems to be okay. There was the nose, which we have not addressed. Inhaler technique, we demonstrated in front of us, and which was acceptable. ICS dose was increased because we thought that the dose he is getting is probably lesser. So we need to escalate the dose further. And we understood that we have not addressed nose. So we addressed nose at this time, and we started on inhaled nasal corticosteroid in this child. And later on, as an add-on therapy, we also started some nicotine receptor antagonist, which is started. At 5 months follow-up, the child was better, but yet not well controlled. So he's still in the partial control mode. So is there anything else which we are missing? We have already escalated the dose. We have checked the technique. We have addressed the nose. So what else we can do? So probably what we have not addressed is environmental factors, or what we have not addressed is probably the obesity. So is there any other investigation which we need to do right now? Or is there any other treatment which we can offer? So as per GINA, if the child is yet not controlled with these type of medications, and you have just done the add-on as a nicotine receptor antagonist, which we have done in this child, then we have to move to the next step. When we move to the next step, now this is the time for the phenotypic assessment of the child, in which we need to really see that which particular type of phenotype this child is belonging to. What I want to say? So I want to say that we need to really look inside the airway to demonstrate the type of inflammation. And we also need to identify the triggers, what other things which have not been rectified, and that is why the child is not getting controlled. So this is a little bit about immunobiology of asthma. So by this busy diagram, we understand that asthma is actually a heterogeneous disease. There is no single pathway. There is no single, you can say, like way through which asthma happens. There are n number of different pathways which are there. So in a particular given patient, it could be, you can say, like choosing any particular one pathway, or probably more than one pathway. Simultaneously, this can also happen that at one particular time, it might be using one particular pathway, and months later, years later, it might go towards other pathway also. So in which there is a type 2 pathway, Th2 pathway, which is involving the interleukin 4 and 13 and interleukin 5, which is actually triggering the IgE production, and then thereafter the allergen re-exposure getting attached to the bound Ig on the mast cell and releasing certain mediators, which are preformed mediators, and causing all these problems of airway, bronchoconstriction, mucus production, and all those symptomatology of asthma. Simultaneously here, IL-5, this is responsible for eosinophilic type of phenotype. And here there is some eosinophilic cationic proteins which are released and which are also responsible for many of the manifestations. So what I want to say, that asthma could be Th2 high or Th2 low. So in Th2 high, that means Th2 pathway, T helper 2 pathway, if it is high, it can be mediated by IgE, it can be mediated by prostaglandins, or it can be mediated by eosinophilic pathway. In the eosinophilic pathway, it can be using certain different interleukins. So we need to really titrate that which particular pathway we are going. Are we going through eosinophilic pathway? We are going through IgE pathway, or we are actually going through Th2 low pathway, which is like more neutrophilic or paucigranulocytic. So this one slide is actually differentiating between childhood asthma versus adult asthma. So both have variable phenotypes. In childhood asthma, so all childhood asthmas are not same. What I want to say, that a child who is probably 4-year-old versus the child who is 10-year-old versus the child who is 16-year-old. So asthma is not same. It is actually changing. So even in childhood asthma, there are different phenotypes which can exist, like from age 0 to 6, from 6 to 11 or 12, or from 12 to 18. If we see, so cough and wheezing are almost the, you can say, like the constant symptoms. Whereas here in the younger children, you will also find some acute episodes of dyspnea and increased work of breathing. Whereas the children are going, you can say, like more towards adolescent age group, then at that time, the symptoms of dyspnea on exertion or chest tightness or chest pain, these symptoms can also come. Whereas in adult, it is, you can say, like with other different causes also. It could be some drug induced, like aspirin exhibited. It could be associated with some nasal polyp conditions also. It could be with ABPA, though this can also happen even in adolescent age group. Now, it has been seen that less than 10 years, it is a male predominance which has been documented, whereas in adolescents and adult, it is more female predominance. Remission is common in childhood asthma, whereas in adult asthma, it is considered as rare. Factors which are associated with severity, especially in children, they are like how long the asthma symptoms are continuing, what is the medication used, lung function, or which different type of phenotype and socioeconomic status. Whereas in adult asthma, there are different other factors like smoking, obesity, and then pheno and IG. They also come into it. So these are the differences. So luckily, in the pediatric age group, the childhood onset asthma, it is predominantly like the allergic asthma. So, or I will say that it is like producing more eosinophils, whereas on the adult onset, it is like more like other different phenotypes which are also there, which I have just mentioned. So let's stick back to the childhood asthma. So in our child, Rahul, we performed pheno, which is the fractional excretion of nitric oxide, to see whether this particular child is having eosinophilic asthma or not, and which is clearly high, which is found to be 190. So for pediatric age group, any value which is more than 35 in children in between 5 to 12 years is considered to be high, which is suggestive of eosinophilic airway inflammation, which is likely, and phenotype more likely to respond to ICS, also called as allergic asthma or eosinophilic bronchitis. So the child seems to be going through eosinophilic pathway, which is like the IL-5 type of pathway. So there are other drugs which have been mentioned in genus step 5, like biologics for Th2 high asthma. It all depends upon that which particular interleukin the child is, you can say like the phenotype is using. So there are different interleukins like IL-4. IL-4 is one interleukin which is considered like a mother interleukin to all the other interleukins. So the T helper cells, they are directly producing this IL-4, and this IL-4 is actually further progressing and stimulating the Th2 cell to produce other interleukins. So if the child is producing like IL-13 or IL-4 and then followed by IgE pathway, then anti-Ig molecules like omalizumab is probably the right choice here. If the child is going from here up till IL-5 pathway, then IL-5 blockers like mepolizumab or benralizumab, they might be the right choice. But if there is a mixed type which is going on, then at that time we can probably hit at the common point, which is IL-4, which is dupilumab, which is going to come up soon in this particular year only in India. So these are the different biologics which can be thought of. And this table actually enumerates that how these biologics actually fare. So if you just see from anti-Ig molecule like omalizumab to anti-IL-5 to anti-IL-4, so the asthma exacerbation, reduction, you can say like the benefits improves from 25% to nearly 70%, and which is going on. But as well as the cost is also increasing. Like omalizumab among these the most economical, and definitely dupilumab is going to be, you can say like the most heavily costed among these biologics. So coming to the other environmental factors which are the triggers in this child, I mentioned earlier that there is dog at home, which is like for past 3 years, and child symptoms are also for past 3-4 years. There are certain seasonal problems, seasonal allergens, which can also be there in the child. And then the environment, like the pollutants and the third hand smoke. So which other investigations? For the, you can say like the type 1 hypersensitivity, the allergens, we need to really test for the allergy testing. So these are the different type of tests which are available for allergy testing. The commonly used, or I will say commonly misused test is total Ig. So total Ig is considered to be, you can say like very famous test for, or is synonymous with allergy for a few decades. But now the scenario is changing, and now we understand that total Ig is not the right choice of test. Total Ig can be increased in a number of other different conditions. So including worm infestations, it can also be high in the high polluted conditions also, viral infections also. So that is why it is not equivalent to the allergy testing or the synonymous to the allergen sensitization. Then there are other tests which are available like the in vitro and in vivo test, like serum specific Ig and skin prick test, which in presence of the relevant clinical history can tell you that, okay, this particular allergen seems to be the culprit here. And then there are, you can say like the world is moving towards the newer or the advanced technique, which is molecular diagnostic. We are not going in detail about that. So in this particular child, Rahul, when we performed the skin prick test, which is considered as a gold standard test for allergy testing, so we found that child was sensitized to house dust mite, which was significant, dog dander, and cockroach. So these were 3 things. We also understand here that dust mite is a perennial allergen, cockroach is a perennial allergen, a dog is there in the home, so it is also a perennial allergen. And dust mite, the concentration increases during the seasonal change, during the you can say like September, October time, when the humidity is quite high. So probably all the 3 allergens are actually matching with the clinical history here. Can we do something for these allergens? So this slide is once again from Gina. It says that yes, there are, you can say like multi-component measures which needs to be taken for these allergens, among which the dust mite is one. The best evidence is for the encasings which are there, like the impermeable covers. But there are other measures which can also be taken to actually target in the reduction in humidity and simultaneously for a temperature control. We need to really get the temperature control and the reduction in the humidity, and then we should be able to reduce the dust. Then pets, there are certain measures which have been recommended by Gina. So the removal of, you can say like pet, which is easily said than done, because if you just advise someone that to remove the pet animal from the home, so the pets are usually considered like more than the family member. So they are so well attached emotionally, they cannot remove them. Then at that time, you have to, you can say, really go towards alternative techniques like washing the pets regularly, keeping pets outdoors, HEPA filters, and all different things. But they are not having that great effect. And then cockroaches. So you need to have some professional pest control there. Coming to the environmental control like smoke. So it has been seen that the incense sticks, which are really actually having these polyaromatic hydrocarbons, benzene and carbon monoxide. So when these are burned, then at that time, the oxidative stress produced is actually 25 to 30 times higher than that of the cigarette smoke. And they actually increases the ultrafine PM particles, PM 2.5 particles and PM 10 particles. So they are not recommended. So it has been said that as the pollutant score increases, the air pollutant score increases, or we can understand the AQI increases, the prevalence of allergic rhinitis and asthma also increases hand in hand. So they are having a very strong direct correlation, which is there. There are different mechanisms through which pollution actually increases allergies. So that could be like because of the greenhouse effect, and because of that, the total flora actually increases. So their pollination increases, their germination increases, and the season lasts longer. So the pollen count increases, their allergenicity increases, fragility increases. So there are different types of things which happen. So ultimately, the pollen actually increases the allergic potential. So what advice we can give to Rahul? So we can definitely advise them for the grandfather that he has to actually cease the smoking, because even the outdoor smoking is very bad. It is considered that when somebody is smoking outdoor, then the smoke particles, the soot particles which are there on their clothes, when they're coming back home, so these particles are coming to the home environment, and ultimately these particles, when they are there in the home environment, so they can actually affect the sufferer. So this is not recommended. No incense stick, no dhoop batti, no agarbatti, no mosquito coils. So these all needs to be strictly avoided. In this particular child, weight reduction is very important. 9-year-old child, and he's having 50 kilo weight. So we understand obesity is a important, very important factor, and we need to really address that. And this is the level B evidence for reduction in weight as per the GINA guide. And then mother wants to actually know that can we actually permanently cure this or halt this allergic march or this asthma type of problem? So I will once again say that we need to really work on all the environmental factors. We need to really work on triggers. We need to really work on all the comorbidities. And thereafter, there is a role of, you can say, like some targeted immunotherapies in which we can really target this Th2 pathway and try to convert this Th2 high asthma to probably Th2 low asthma. So which is called as immunotherapy. So in immunotherapy, what we are doing is we are trying to shift the immune balance from Th2 to Th1, and in which the harmful interleukins, like I mentioned, IL-4, IL-5, they all reduce over a certain period of time. And then the good interleukins like IL-10 and TGF-beta, they increase. So actually it stimulates the production of tolerogenic dendritic cells, and then it suppresses all different types of, you can say, like allergic manifestations or asthma manifestations. Different types of immunotherapies right now available: sublingual immunotherapy and subcutaneous immunotherapy. Though subcutaneous immunotherapy is considered to be more effective, but safety is more better with sublingual. GINA recommends right now about the sublingual, but in India right now, we do not have either of them in the standardized format. So people are doing them, but they are not that much standardized, but yes, they are effective. So I will be, I think, in the last 3 or 4 slides. What about air purifiers? So this is a frequent question. So that's why I have brought this question here. So there are certain factors which are important factors which one need to consider before buying air purifier. So first of all, we need to really see that which particular room you want to install. Right now, I am sitting in a small room. If we are in an auditorium in a hall, then we are in a big room. So all room sizes are not same. So we need to really take the 3 dimensions of the room and then go to the vendor. Then what vendor will do, he will multiply these 3 dimensions with a certain multiplication factor, which is I think 60, and then they will come out to a particular figure, and they want that it is a clean air delivery rate. So the ideal aim is that the clean air delivery rate should be at least 4 to 6 air exchanges per hour. So it is possible that one air purifier, which might suffice a small room need, but a similar type of 3 or 4 machines might be needed for a bigger room. So that is why it's not that you buy the air purifier and you place it anywhere. It's not like that. You need to first, you can say like choose the room, and then thereafter you take the dimensions of that, and then you go to the vendor and ask him for that particular machine so that it can work better. Second is about the MERV. What is MERV? So MERV is minimal efficiency rating value. So it all depends upon the pore size of the filters which are there in the air purifier. So these pore size filters, as per the size of the filters, like if you remember the COVID time, so there were different type of masks which were available, N95, N90, and all these things. So this all were based upon the pore size of the filter. So depending upon this pore size, this MERV rating is given from number 1 to 20. So 1 to 15 are not useful at all. So suppose if you buy a machine which is probably, you can say like more economical, more cheaper, coming in a discount or something like that, and at that time that MERV value is only 12, it is actually not serving the purpose. Though it will be called as an air purifier, but it will not serve the purpose. You actually require a filter value, MERV value, in between 16 to 20. So if you mention that to your vendor, they will tell you, okay, this particular machine will be having this. Then the other point is about the location of the unit. Majority of the time, air purifier we buy, but we keep that in the side of the room, which will not work effectively. So air purifiers suck the air from the environment, and then they filter it, and then they release it. So for which they require a good amount of air in the environment. So air purifiers ideally needs to be kept in the center of the room. Ozone generators. So there are certain air purifiers which generate ozone, which is bad. Ozone generation in the respirable environment is bad. Ozone is a respiratory pollutant. It is a respiratory irritant. It can aggravate the symptom of asthma. So ozone generators are not recommended, should not be used. If the air purifiers are having some activated carbon layer, this is good. Reason behind, because these layers actually absorb the harmful odors, the harmful gases, and that is why they are considered to be good. The other important thing is periodic filter cleaning and change, which is important as per the manufacturer recommendation that you need to, you can say like probably yearly or 6 monthly, whatever the manufacturer recommendations are there, you need to do that. And then power consumption. So power consumption, obviously we want a higher star rating air purifier so that the power consumption is less. What about indoor plants? So many times we keep some indoor plants. So are they good or they are not good? So we need to really understand that which particular type of plants are more polygenic. That means they are producing more pollens. Which particular season they are more producing pollens. We need to actually keep those type of plants inside which are having, you can say like very less number of pollen production, or their pollens are heavy. They do not travel in the air so much. They are sticky. So these are the, you can say like the indoor plants which are recommended, or the natural air purifier plants which are recommended, and like aloe vera and peace lily and all these type of spider plant, these are there. So these are considered to be like snake plants. So these are considered to be good plants to be kept indoor, or probably to be given as a gift to someone else. So take home points are, childhood asthma is not like a miniature of adult. It is different from adults. It is a time to think beyond inhaler. We need to think a lot of things. We need to think about mimics. We need to think about correct technique. We need to really think about comorbidities. We need to think about triggers. We need to think about environmental factors and a lot of other things. And allergen immunotherapy is probably the only disease modifying available therapy which is there. So it is the era of precision medicine. And we need to really, you can say like, see each and every individual, each and every patient as their own, because every child is different. Even the same child at different course of time, different period of time might behave differently. So we need to each and every time assess and reassess that why the child is not improving, where I am wrong, where the environment is wrong, where the things are going wrong. So we need to really see that thing. With this, I will stop here. Thank you.
Thank you, Dr. Neeraj. That was a comprehensive review and a nice way of covering everything, taking an example of a child who was 9 years old, that is, could perform spirometry, was obese, had allergic rhinitis. So lots of points could be covered and then he was not responding so easily, then you had to change treatments. It's not really change, add, and so on. So we have been able to cover almost anything and everything, and very nice of you to have covered the environmental factors also, which many a times we either, because we need a lot of time to convince the family as to how to go about doing this, and sometimes we also don't have very clear answers to the queries that there is. So we try to kind of avoid them. And finally, the allergy testing and the allergy treatments, those also you covered and told us that although they are effective, there are some limitations in their use in our country. Although I know many people are using this therapy as well as testing, but standardization is a big question, and that is why probably the response that we get in our patients is not the best, and also it sometimes loses credibility, not only among pediatricians and among our professionals, but also among patients. So nice of you to cover almost anything and everything. Dr. Deepak, you want to add something, please?
No, I think it's perfect. I was just thinking about the points that Dr. Neeraj has covered beautifully. First, he started with saying that the diagnosis is clinical, that we all should understand. And he addressed the use of pulmonary function tests, demonstration of the reversibility, and excellent presentation of to make it so easy about oscillometry, that how and what we do among the children who cannot perform on this spirometry, the age group of less than 7 years, where you can try 2 years onwards, a long way to go, but. And he also highlighted, as you said, that the issue of addressing the triggers, indoor, outdoor, both, we need to look into that. Very nicely explained in one slide about various phenotypes, the whole cascade, and how immunotherapy can help. So I think these are the points. A regular follow-up is very important, and then you would know exactly whether asthma is controlled, poorly controlled, or uncontrolled, and then you can accordingly step up, step down, or use now what is coming up is biologics. How it was Neeraj's excellent presentation, how you explain in one that slide how and where which biologics will work and why. So I'm very happy. I think it's absolutely complete lecture on asthma.
So there are some questions also, Neeraj. One says, how frequently follow-up of oscillometry is required? So probably the same thing can be extended to how frequently would you do a pulmonary function test, spirometry, in a patient who you have, let's say, diagnosed and started treatment on?
So I usually answer this question, sir, in this manner, that any testing, whether you are doing probably a CBC, or you are doing a chest X-ray, or you are doing a CT scan, or any PFT, so you should first ask yourself that if you get some information, so which information you want and what action you are going to take. If you don't need any particular information, or you're not going to take any action, then don't do that. What's the need of doing that? So initially you want to make the diagnosis of asthma, so definitely proving the reversibility you want for the initial one. And then thereafter, if the child, the asthma symptom score and everything is going fine, the child is doing fine, and then at a particular time you are able to taper your, you can say, like medicines, then there is no need of doing it very frequently. You can probably do 6 months or 1 year, how the things are going on. But suppose if the things are not going in the right direction, then at that particular time you need to really think once again about your diagnosis. You need to think about stepping up the treatment. Then at that time you need to probably go and do it more frequently. So there will not be any particular characteristic number which I would like to see give. So every child will be different, and you need to really see, but probably a safer number will be like 6 months to 12 months.
I also think that there is no schedule that can be given, and every patient there has to be an individualization. But one thing that I commonly practice is that when we are stepping down the treatment significantly, let's say child was getting 4 puffs a day and now we come to 3 and then to 2, I want to maybe halt there, because from the history I know that this is a prolonged asthma who's let's say started from some 4th stage, and now we are at, we can say that it's a good control, but we have brought down the dose to half. And I might like to confirm by a spirometry and looking at these small airway disease by other means, and maybe at FENO also, and then see whether I can go down another step. And then when I'm almost about to stop, then again, maybe a time when we would like to do this. But this applies to those who've been on inhalers and such things for months and years. Those who have been there for a few weeks, and then you think that whether we think or the family thinks it's all okay, and they stop it, and then they don't come to you, and then they come back again after some time, then probably once again you try to do this test to convince them here is an objective evidence that your child is suffering, and please start your treatment and stick to it more routinely than what you have done earlier.
Agreed, sir.
Oh,
Totally. agree.
yes, sir. I'll just add one point what we do, that if the child was bad enough and came to our ER and then needed an IPD, admission, then we do see this child little earlier. And once he's controlled, and exactly what Dr. Neeraj and Dr. Chok has mentioned.
One point I would like to add on regarding the pheno. So this I am telling you with the experience of past, you can say like 2.5 years, we are regularly doing pheno at our unit now. So when initially we started doing pheno, especially the bronchial pheno, and we found that if we are absolutely going with the numbers, like I have shown you that in children more than 35, there is a clear cut that it's a eosinophilic asthma. When we are going absolutely with the number, sometimes the numbers also, you can say like, can be, you can say like catchy. How? Like what can happen that if a child who is actually having a predominant rhinitis, but his symptoms are cough. So you don't know whether the cough is because of asthma or it is because of rhinitis. And he is actually having predominant rhinitis. And you do nasal pheno, and the nasal pheno is coming out to be 800, 1000, 1200. And then you do bronchial pheno. The bronchial pheno might be 80, but actually he is having normal lung functions. So it is the contamination from the nasal pheno that you are actually getting some amount of bronchial pheno there. So what I'm saying is that no particular number anywhere is sacrosanct. We need to really see the patient, that what exactly is happening and whether he's responding to the therapy or not. And all the other, you can say like clinical features, investigations, we need to combine them together. And if it is going all things in one line, then we have to go. We cannot treat any absolute one number for any particular thing.
Neeraj, what is the recommendation of GINA 2024 regarding pheno? Doing and interpreting.
Sir, this is like wherever it is available, it should be done.
But then its value in diagnosis, probably not great. Its value in following a patient where you have done it and somewhat better, and its value in getting additional information of the upper airway and the nasopharynx, pharynx, and the nose, also somewhat yes. That's what I would think about briefly.
Right. Right, sir.
Okay, if there are any more questions. The second question is for the administrator to answer. When can you get the recording of this? Yes, it was a good, very good, in fact, talk, and yes, recording should be in demand.
So we shall shortly be putting all our faculty lectures on a YouTube channel by the name of MEDNEW, MEDNEW.
Okay, right. So from our side, thank you so much, Neeraj.
Thank you, sir. Thank you.
Thank you very much. Dr. Pankaj?
Thank you so much, Neeraj. It's always a pleasure listening to you.
Pankaj, you've been muted.
Thank you, Dr. Chug, for your comments at the right stage to make the perspective clear for physicians and pediatricians. And Dr. Deepak Ugra, most welcome, and very, very useful comments from your side also. Thank you, everybody.
Thank you. Good night, everybody.
Good night. Good night.
Good night.